Thank you. It was a boring task, so I did it with Bo. No, sorry. If you look carefully, we identified 44 articles, and among them, 36 randomized controlled trials. You have the list is conventional EVLA versus radiofrequency ablation, and so on. I will go to details now. That is a series of radiofrequency ablation versus classical conventional open surgery. We have 9 articles, 7 randomized controlled trials. What is the summary? Almost all randomized controlled trials concluded that after radiofrequency ablation, there was less postoperative pain, faster recovery, and earlier return to work and normal activities, as well as higher patient satisfaction. The longest follow-up is 3 years, and there is no difference in terms of clinical result between classical surgery and radiofrequency ablation. So short-term is in favor of radiofrequency, long-term, no difference. Comments. It must be noted that in all series, the bipolar catheter closure plus was used, knowing that the new one, closure fast catheter, has given better results in case series. It should, however, be pointed out that modern, less invasive open surgery, as described by Marzia this morning under local anesthesia in the office setting, is showing similar good outcomes in case series reports. Now we move to conventional open surgery versus endovenous. We have 13 articles, 11 randomized controlled trials. You have the list. If you want, I can provide you the list. It has been published also in Flebol Anthology. I just updated it. So that is the list of all the articles. Results. Conventional open surgery versus endovenous laser ablation. All randomized controlled trials use burr-typed fiber 980 nm, except 3 who used 810. Observation time was 1 year or less in 9 studies, very short, and 2 years in 4th study. Quality of safety and early efficacy was high, with no real difference between the two groups. Concerning the recurrence, there was a difference at 1 year, but at 2 years, there was no difference. No randomized controlled trial has been reported with the new radial or jacket-tipped laser fiber compared to open surgery. Now I can speak about endovenous laser ablation versus cryo stripping. We have 3 articles, only 1 RCT, the same group. Cryo stripping was significantly faster, less costly, but cost-effectiveness ratio was non-significant. No difference in terms of recurrence at 2 years. Endovenous laser versus endovenous laser. We have 5 randomized controlled trials. You can see the list. I will go to detail. High ligation combined with endovenous laser ablation does not improve the outcome compared to EVLA without high ligation. Concerning the comparison between 1,500 nm versus 980 nm, immediate postoperative course, fewer clinical side effects with 1,500 nm, but P is not significant. At 6 months, there is a similar occlusion rate. The last one was EVLA 1,470 nm radial fiber, gives at 1 month's follow-up less postoperative pain and better venous clinical severity score compared to 980. Another one that has been published this year is a comparison of endovenous laser versus foam. It's a very short term, 3 months, but ultra-guided foam sclerotherapy is 3.15 times less expensive than laser, with comparable effectiveness in terms of above-knee grid venous obliteration, Aberdeen varicose vein questionnaire, venous clinical score, but 56 versus 6% in the group of sclerotherapy required additional foam. Now, open surgery versus chemical ablation. We have 5 RCT in 6 articles. The first randomized control, very short-term follow-up and did not bring any conclusive result. Conversely, the 6th one by Evi Kalodicki is a full documented 3-5 years follow-up RCT. It has been published recently, and the conclusion is that the venous clinical severity score, the venous severity, VES, and the physical component of the SF-36, there is no difference. The Aberdeen varicose vein questionnaire was significantly better in the surgery group, but the margins were very small and with no clinical significance. Adding that foam is less expensive, one can conclude that cost-effective ratio is in favor of foam. The only surprising point in this trial is the complementary high ligation. It is generally admitted that high ligation enhances neovascularization of the groin. Besides, complementary high ligation brings up a question, should the outcome be equivalent in absence of high ligation? We don't know. Phlebectomy, that is an old one, because liquid sclerotherapy was used, so no value. The last one is endovenous laser ablation versus radiofrequency ablation, 5 randomized controlled trials. The material used was for radiofrequency ablation, 4 closure catheter, and 3 closure fast, 1 closure plus, and 1 cylinder airfreight. For AVLAs, 3 810 and 2 980 nm bare fiber. Less breathing and less pain with closure fast. But new laser fibers are developed, radial or jacket tip fibers, and Kabnik has reported on a pilot study comparing radiofrequency closure fast versus endovenous laser that there was no difference between the 2 techniques. And the last one, of course, is Rasmussen with 4 ends. And you can see at 1 year that by duplex scan examination, the bridge-saphenous vein occlusion was better in group 1, 2, 3. That means surgery, laser, and radiofrequency, compared to the group 4, which is foam. Clinical recurrence, no significant difference. We are waiting for long-term result now. That is the only randomized control trial comparing the 4 operative procedure. 5 years follow-up is ongoing. We are waiting for, as I said. Discussion. Firstly, when long or medium-term outcomes comparing new thermal ablation techniques become available, the development is so rapid that the material or device employed in the randomized control trial is frequently no more used, which is very important to know. Second, most new procedures are operator-dependent, and when 2 or more new techniques are tested in randomized control trial, it is important that the investigators are well trained in all of them. Behind the brief description of a procedure, we don't know how precisely it was performed. For example, high ligation plus stripping has evolved as it was presented this morning, and is presently less aggressive and invasive. Of course, randomized control trials are important in the evaluation of new procedures. Skepticism about conventional randomized control trial in non-pharmacological interventions such as surgery remains, and so-called expertise-based randomized control are suggested as an alternative where participants are randomized to clinicians with expertise in intervention A or clinician with expertise in intervention B if the clinician perform only the procedure in which they are expert in. Accurate analysis of the presented randomized controlled trials, I know it's boring. It's difficult as hidden bias can be hard to identify. For illustrating this point, in some randomized controlled trials, operatives were performed either under local tumescent anesthesia or general anesthesia, which makes a big difference in short term, of course, you know. So you cannot compare that is a bias. The final conclusion, based on the presented randomized controlled trial with the caveats mentioned, is that the difference between the modern open classical surgery and the new endovenous procedure are insignificant, and that no treatment modality can be recommended as superior to another. In my opinion, it depends on the status of the patient. That was not discussed this morning, but I think it's a very important point. In some patients, probably surgery is better, endovenous for other, and foam in the other patients. Thank you.